Welcome back to our YouTube presentation on the Value-Based Modifier program. This is part 2 of the series. It will focus on providing additional details behind the program so that you can gain a better understanding of how it will work. Remember that this is a program that is being phased in. Practices with less than 10 providers are not impacted in 2014. However, we do expect that the program will apply to them starting next year. Practices with 10 to 99 providers are participating in 2014 for the first time. Their 2016 Medicare payment rate is impacted depending on whether they report PQRS measures for the calendar year 2014. However, as long as you report the measures sufficiently to avoid the PQRS penalty, you won't get additional payment cuts, regardless of your performance on those quality measures. On the other hand, practices with 100 or more providers were part of this program last year, and for these large practices, they will face payment cuts if they fail to report quality measures or if their performance on cost and quality measures are substandard. For some practices, it will be very important to understand exactly how CMS will determine the number of providers. First, in October of this year, CMS will generate a list of practices based on the NPIs that are listed for the practice's tax identification number in the PACOS system. In this example, practice A, B, and C would be on their list, but practice D would not be. Next, in March of 2015, CMS will analyze actual claims filed by every TIN from Step 1. If some of the NPIs in that practice did not actually bill any services to Medicare for 2014 dates of service, then this might be sufficient to remove the TIN from the final list of practices impacted by the VBM program in 2014. In our example, Practice C had only 8 NPIs who actually billed Medicare, so they would not be included in the final list. Practice D may have added 2 NPIs late in the year, and they actually had 11 total providers who billed to Medicare, but since they were excluded in October, they are still excluded in the final list. Now let's delve into the different cost and quality measures that will be used to determine a practice's tier. Cost measures will come entirely from claims data submitted to CMS for patients seen in 2014. The first cost measure is the average amount that Medicare paid for Part A and Part B services for a group of Medicare patients that CMS assigned to your practice. The second measure is similar, except it is limited to only those Medicare patients assigned to your practice who have one of 4 different chronic conditions. Obviously, it's very important how this assignment is done. It's a 2-step process that results in every Medicare beneficiary being assigned to just one TIN. In the first step, Medicare will look at all services billed for a specific patient during 2014 and identify the total allowed charges for primary care services by the billing physician, looking only at those with a taxonomy code indicating that they are a primary care provider. The patient is assigned to the TIN of the billing provider who had the largest total allowed charges for this patient. Some patients will not be assigned because they didn't have any services from primary care physicians. In the second step, CMS will assign these patients to the TIN that had the highest allowed charges for outpatient E&M codes, regardless of what provider in the group saw the patient. Essentially, the concept is to assign the patient to the practice that provides the bulk of the patient's primary care or outpatient E&M services. If a TIN has less than 20 patients assigned through this methodology, then these 2 per capita cost measures will not be calculated for that practice. The third cost measure focuses only on Medicare beneficiaries who were hospitalized during the calendar year. The measure looks at the average Medicare cost per patient who was discharged and measures the cost from 3 days prior to the admission to 30 days after the discharge. For this measure, Medicare patients are assigned to the TIN that had the highest Part B charges during the inpatient hospitalization. And again, a group with less than 20 assigned patients will not have this measure calculated for them. The three measure results are then adjusted to reflect differences among groups based on how sick their assigned patients are, the geographic component of Medicare payment rates, and the specialty distribution of providers in that specific group practice. The adjusted scores are then weighted equally to provide a single composite cost score for the practice. This composite cost score is compared to the national mean for all practices to determine whether the practice falls into the high, average, or low cost tier. In a similar manner, a single composite quality score is calculated for each practice. It is comprised of PQRS measures reported by the practice and some additional measures calculated from claims data. Every PQRS measure reported for the group or for any individual provider in the group is considered. If there are less than 20 patients in the denominator of a measure that is reported, it's excluded. You'll remember that each PQRS measure is assigned to one of 6 domains. CMS will combine all the measures reported for a practice and weight them equally to generate up to 6 domain scores for that group. Next, CMS calculates 3 outcome measures for the group from claims data. Patients are attributed to a practice in the same way as the per capita cost measure. As you can see, the measures are all related to patients who were hospitalized during the calendar year. The 3 outcome measures are combined to create a single outcome composite. And then this outcome composite score is equally weighted with the 3 to 6 domain scores to yield a single composite quality score for the practice. This final quality score is compared to the national mean and identifies which quality tier the practice will fall into. The VBM program is very complicated, but hopefully you now have a somewhat better understanding of what will cause a practice to be placed into one of the boxes or tiers shown here. Let's review the main concepts of the program. Remember that CMS's statistical analysis is designed so that the vast majority of practices will fall into a white box and will see no impact on their reimbursement unless they do not submit any PQRS quality measures. A practice with 10 or more providers who does not successfully report at least 3 measures will receive a 2% PQRS penalty and a 2% VBM penalty in 2016. Practices with 100 or more providers who report quality measures and fall into the red boxes will also receive a payment cut in 2016. The program is budget neutral so that the dollars saved from practices that have payment cuts from the VBM program are then redistributed to the practices that fall into the green boxes through higher reimbursement rates in 2016. In the fall of 2014, all practices will be able to review feedback reports that calculate their quality and cost tier using 2013 data. You'll be able to use these reports to get a sense of what your status may be in 2014.